Okay, I just want to give you a community health perspective. Although I'm actually working as a national coach for Sir John Oldham's work stream, I do have quite a bit of experience in assistive technology, and I actually started using it in 2005 as a community matron. So I just wanted to run through my experiences of actually using it, but also to show you how it fits into the national agenda. So I just wanted to, as I said, go through the background of it and put it in some context and talk about the case for change and why we actually need to consider using this. I'll just give you a brief overview of the work stream, but then I want to focus on the benefits realisation, actually using it, and what it meant as a clinician for me and for my patients actually using it. And finally, just to show how it fits into the three key drivers. So my background really, I was a practice nurse and a specialist nurse for many, many years. So chronic disease management was my bread and butter. But in 2005, I started working as a community matron, specialist community matron, and we were actually given assistive technology to roll out as part of the model. We had the opportunity then to go out and talk to all of the GPs about how the matron model was going to work and how assistive technology was going to support us in doing that. It quickly became a tool in our toolbox to help us manage our patients. The Kent Telehealth pilot was running alongside that, and they actually monitored the effectiveness of rolling this assistive technology out under the matron model. So it was a case management approach. Now we had, for those of you that haven't seen the model, we had over 250 people on the trial, and we actually managed 90 patients on our caseload, my colleague and I. And we saw significant benefits in actually using the technology. We saw significant reductions in bed days, and I'll go on to those in a moment. But if you haven't seen the Kent Telehealth report, it's certainly worth looking at because it does focus on the long-term conditions and the impact that it can actually have. Now, the whole systems demonstrator, I won't go into it too much because Stephen Johnson's going to talk about that, but I was involved in that as well for the 2-year period that it was running. And now I'm lucky enough to be working on the commissioning development programme for the long-term conditions workstream with Sir John Oldham, and it fits into there quite nicely. So the context really, this is not quite as good as your description, but we all know that 70% of health and social care spend is focused on long-term conditions and inpatient bed days, and for the GPs in the room, they'll know that that covers about 50% of your GP appointments. And if you look, even the outpatient and A&E appointments, it focuses on a lot. So there's a lot we can do with the assistive technology to target this. And as we all know, that's expected to rise quite substantially. I'm not going to read the figures out because you can all see that, but it's huge. It really is huge. And the healthcare system is not sustainable, so we've got to get smarter in how we manage these patients, and assistive technology is one way of actually doing that. Now, the QUIP work stream, led by Sir John Oldham, is an evidence-based work stream with the 3 primary drivers of risk profiling, which we've touched on already, integrated care teams, which you've all mentioned, virtual ward, and the systematic empowerment of patients to self-manage. And the assistive technology, telehealth, fits into all 3 of those. So for me, I'm going to give you some examples of some patients in a moment, but these are the benefits that I found in using the assistive technology. One of the biggest and the most amazing was actually it eliminated white coat syndrome. You actually get a true reflection of a patient, and for those patients with hypertension, you know that the nice guidance is to use 24-hour ambulatory monitoring if you're looking at diagnosis, because you don't always get a true reading. And using technology, you get a much better reading because there's no clinician sitting in front of the patient. They're at home, at rest, doing their blood pressure readings. And as long as they've been taught how to use the equipment properly, you can be pretty sure that the readings are accurate. It certainly prevents and reduces the impact of exacerbations because you get an early warning indicators of that change in their health status. If you can act quickly enough and get their clinical management plan or step up their emergency treatment, you can reduce the impact and also the worsening of an exacerbation. Having the technology, having the readings actually gives you the ability to do that because you've got more readings than you would normally have. Because as much as I would have liked to visit my patients every day, I just don't have the time. With the technology, with the data that the telehealth generates, you've got that ability because you get it every single day. It's certainly reduced hospital admissions because of the previous point that I've made. You were able to step up quickly with your management plans. It improved medicines management. If we initiated treatment, we could see very, very quickly the impact that our medication was having. So if you look at a patient on a beta blocker, for example, that slows the heart rate down, you know that if somebody's quite sensitive to it, it can drop their pulse rate quite quickly. That's your falls. That's the patients with a fractured neck or femur ending up in A&E. If you get in quick and see those results, you can reduce the medication quickly enough. It certainly supported QOF clinical guidelines because you've got all of that readings there, and for those GPs in the audience, I'm sure that is a bonus. But in terms of my caseload management, it enabled me to be more proactive in my approach. I was visiting patients opportunistically before, but with the telehealth data that was coming through, you knew which patients you needed to go and see first. There was a much more guided approach to actually visiting these patients, because you were triaging those patients first thing in the morning and seeing the ones that you needed to visit first, as opposed to leaving them as the day progressed. It promoted self-care. Patients got to know their numbers, they knew what their readings were. It changed the dynamics of that patient-professional relationship. They would go and see their GPs in the knowledge that their normal readings were, their SATs were normally 95% on air or 89% on air. It changed that approach to the way the patients related to the clinicians. And as I said, it empowered that patient. There's a holistic approach to the patient because you've got a whole range of readings depending on the readings that you targeted for that particular patient. There's certainly a reduction in the amount of healthcare professionals involved. For example, some of the patients that we had, we gave access to the consultants in the hospital, we gave access to the consultants in the A&E department. We were able to reduce the amount of outpatient appointments because of that, because we could have discussions over the telephone. They log on the system, they can actually see those readings. So there's a definite reduction in healthcare professionals involved because you're sharing information. The accident and emergency departments would have the information that they wouldn't normally have, because when you present at A&E, you've got a window of information that the registrar or the house officer makes a clinical decision on. But if you've got a history, it's a safer clinical decision because you know what's normal for that patient. You've got, as I said, all of those benefits, and I will give you some examples of them in a moment, but I just thought it was really important to show you my experience of actually using it. Now, I'm just going to give you some patient examples. As I said, this is an example of a patient living with heart failure. This particular lady, we found as little as 1.5 kilograms of fluid overload, and this lady developed an irregular heart rhythm. She invariably ended up in hospital, either in SVT or whatever. And actually, in this particular case, because we saw that subtle change, there was a clinical management plan put in place with the cardiologist, and we actually successfully titrated a diuretics several times to avoid potential admissions. And she was a lady that was particularly sensitive to beta blockers, and we note within a day that her pulse rate had dropped. And one could argue that the clinician would have gone in anyway, but you're picking it up sooner rather than later. Patient with type 2 diabetes, for example, a maximum tolerated dose of salt. Apologies for those of you in the audience who are not clinicians, I do apologise. Treatment for diabetes, insulin initiation and titration was successfully undertaken safely with the use of telehealth. We were able to monitor the BP much more closely with the system. The patient became more empowered, but they felt supported in doing so within the community. So for me, the potential uses, they're very, very broad. I mean, certainly the complex patients with multiple morbidity, certainly, but even single morbidity. But that's a long-term use, but there's also short-term gains as well. You can use it in gestational diabetes. Newly diagnosed heart failure patients, when you're optimising their treatment, when you first start on that programme, you can have much more closer interaction with the patient and monitoring their drug interaction safely. Newly diagnosed diabetes patients, rapid response, early discharge. If you're trying to get patients out of hospital sooner, and reducing their length of stay, you can put the technology in to support them at home much more safely. And within the quick work stream, as I said, assistive technology fits into all of these three strands. If you're looking at risk stratification, you're looking at your patients with a high risk score and perhaps using case management for those particular patients. But if you want to have an impact on those patients lower down with a lower risk score, you can use the technology to support them until you've got the resources to actually go in and do a more interactive approach. Integrated teams, using the technology to communicate between that integrated team, you can reduce the amount of visits, you can reduce the amount of visits to hospital with their integrated team having access to the data. Systematisation of self-management. We've got to get patients to have control over their health. They've got to be able to safely manage it. The technology gives them the confidence to do that. And finally, I just want to pick up on a point that a couple of people have actually made about technology replacing clinicians. It doesn't replace clinicians at all. And for those of you that have not seen this slide by the Department of Health, in 1 year there are 8,757 hours that a patient has to self-care. Within that year, for an individual living with just one long-term condition, they go on average about 3 hours of professional care. On average. Given the technology, given the telehealth, actually increases the amount of professional contact that you're actually having with them, not reducing it. So for me, I mean, it's the best thing since sliced bread. Thank you very much.